presentation, it's my pleasure to introduce Angela Craig. She's a clinical nurse specialist for ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. Her career began in Illinois as an ICU staff nurse. She went on to become a clinical nurse specialist. Angela has been a clinical nurse specialist for 2 telemetry units at South Suburban Hospital in Hazel Crest. The last 11 years, she's been in her current role as a clinical nurse specialist for the intensive care unit in Tennessee. She's developed and chaired the sepsis team at her hospital and was the first hospital in the state of Tennessee to become sepsis disease specific certified through the Joint Commission. She's presented nationally on the topics of sepsis and hemodynamics and has published on sepsis and co-published on heart failure. She also consults independently for the Tennessee Hospital Association, where she does site visits and helps hospitals with their sepsis initiatives and the development of their programs. Welcome, Angela. Thanks for joining us.
Thank you so much. Thanks, everyone. I'm so excited to be able to speak to you about sepsis. I do need to make a disclaimer about my voice. I don't always sound this way. I was just telling those guys I'm recovering from flu A and B. So I was at work on Monday and just didn't feel right. And so I have been quarantined to my home, but luckily I could log in and I'm feeling better. So it's all good. It's just my voice might sound a little different. I have plenty of fluids here to keep me able to talk. So let's talk and let's get started. The title is Compliance and Community, and basically talking through how to make our sepsis program improve. And I do put some disclaimers on here, just some disclosures, some things I work with currently, the advisory board for Sepsis Alliance, and I'm on a few other committees or a few other groups where I help. But what I want to basically tell you is nobody tells me what to say. I am all about best practice. I'm all about discussing what we need to discuss. So even though I'm consultant for a variety of people, this is all based on evidence. Next slide. We are going to discuss the 3-hour and 6-hour bundles and hopefully really give you some more innovative ways to improve bundle compliance. I don't know about you guys, but this has been a struggle for us. This last year has been a rough year for us, and I consider my hospital to be a leader, and yet we have struggled, so I'm right there with you guys. And I really want today to be as interactive as possible with your chat, and we'll hopefully get to a lot of the questions. And I'm going to try to go nice and slow so we can cover a lot of really important topics. We're also going to talk about some community opportunities to hopefully help us decrease readmissions. This is a huge challenge, and we're all struggling with that. So this is a picture of my hospital. I am a community hospital. It's about 247 beds. It is a regional referral center in the upper Cumberland of Middle Tennessee. It's kind of a unique situation. We don't have hospitals on every street corner like some of you guys might, but we have our own set of challenges, but we definitely serve a lot of small rural hospitals. So once again, the importance of really, trying to reach out and teach our smaller rural hospitals about what they can do to better have better outcomes with the patients that they send to us, and we can talk on that just momentarily. She's already mentioned, we're happy to say we were the first in the state of Tennessee to become disease-specific certified through the Joint Commission. I'm not sure if you're aware of what that means, the rigors of that, but we just recertified just really literally a few weeks ago. So we're recertified for another 2 years. This is an exciting time just to get a little bit of credit for all the hard work you do. If that's something anybody is interested in, that's a whole nother topic, but exciting days. So let's talk about sepsis and what an epidemic it is. The fact that so many of you are on this conference call is because you're struggling probably with this challenge. Greater than 700 people die from sepsis a day in the United States. And with my last slide deck, before I updated it, it was 500. So it's only increased. And, I think we all think we're doing really well with sepsis, or I think some of us would believe we might be, but the reality is the high mortality rate is still fairly dismal, and we have a lot of work to do. You can see it's the third leading cause of death. It affects more than 1 million Americans per year. So we have a lot of work to do. When you think about it as far as how much, how significant this is, sepsis kills more than breast cancer, prostate cancer, and lung cancer combined. So this is a huge amount of deaths per year, and it's a challenge. Per the CDC, they pretty much have categorized sepsis in 4 major topics. So about 80% of sepsis cases begin outside of the hospital. Next slide. And 7 in 10 patients with sepsis had recently used health services. And they have determined that the 4 most common types of infection are lung, and I think you guys would agree with me, we see a lot of pneumonia. About 35% was lung infection, about 25% was urinary tract infection, and then about 11% gut and 11% skin. Now we know there's a lot more, but the reality is those are our 4 major ones. Next slide. When we think about ways to improve bundle compliance, one of the things I'm just really strong about is that we have to be able to recognize the signs. So for many of you, I know this is just going to be just a review, but I think it's important to make sure we are all on the same page. There are some challenges with the definitions here. So we're going to go to this next slide and talk through these definitions. The 2017 guideline definitions talk about sepsis and septic shock. So I'm sure you guys are well aware. We're going to go about 2 slides forward, and I'm sure you're aware that they have taken out severe sepsis. So sepsis, and this is per the national guidelines. So sepsis, and it spells out that the life-threatening organ dysfunction caused by dysregulated host response to infection. Then they have septic shock as being a subset of sepsis with circulatory and cellular/metabolic dysfunction associated with a higher risk of mortality. Now, I wanted to review this with you because we're going to go to this next slide and talk through these sepsis 3 definitions just a bit. This is not the CMS definitions. These are the new definitions that were in the latest Surviving Sepsis Campaign guidelines. So there are national guidelines, and then there are resources that we go with the CMS that are based, a lot of what CMS has in them are based on the guidelines, but the definitions are a bit different. So I want to mention that Sepsis 3 does away with SIRS criteria. It also does away with severe sepsis. And the way they have it to where you can determine what these are, sepsis is infection plus 2 or more SOFA points, which SOFA stands for sequential organ failure assessment. And then your septic shock is vasopressor dependent hypotension plus lactate greater than 2. All right, so let's go to this next slide, and I'll try to spell this out a bit for you. So your Q SOFA, if you have 2 or more of these, then you evaluate for SOFA. So your Q SOFA are respiratory rate greater than or equal to 22, altered mental status, and systolic blood pressure less than or equal 100 millimeters of mercury. So very different from our CMS standards, right? So, but what's important to know about this, there are a lot of places that are now declining payment because we don't have sepsis or septic shock criteria based on sepsis 3. But I want to warn you that if you try to just focus on sepsis and septic shock, you may find, I have one hospital that I've worked with that found that actually their mortality increased when they went away from the CMS definition. So I just want to mention this, that this is a point of something to think about. And then your SOFA criteria, and you can go to the next slide, the SOFA criteria are more your organ dysfunction. So this is just kind of a workflow. And when I've reached out to colleagues, they've really recommended keep doing what you're doing as far as with the CMS definitions, measure Q-SOFA and SOFA scores in addition to current practice to assess for high risk of death until CMS changes or there's a large prospective studies that are performed. So more to come on this. We at my hospital, we have not incorporated Q-SOFA or SOFA yet. We are getting some denials, but our outcome measures, our mortality rates look pretty good. So we're just kind of determining what to do at this point. Next slide. So here's what our challenges with the sepsis 3 definitions. SIRS are not part of the definition. And basically the point about SIRS is the most appropriate use for SIRS is that its presence prompts an immediate search for infection and possible source and organ dysfunction and its possible companion. I usually tell my staff to think about the question, does the patient have a known or suspected infection before they look at SIRS criteria? Because so many people say everybody's got SIRS, right? There's so many reasons why a patient would have SIRS. But if you have SIRS with that known or suspected infection, that's where there are concerns. Late recognition. Sepsis, we know, is a problem only when life-threatening organ dysfunction is already present and it fails to recognize the spectrum of the illness. So it is important to look at organ dysfunction. One of the areas that does concern me is that with these new definitions, it does not recognize cryptic shock. It makes you have to have hypotension and a high lactic acid, whereas with the CMS definitions, you can have a normal blood pressure and a high lactic acid, and that's called cryptic shock. And these patients, many times I say to my staff, that is the calm before the storm, and hopefully we can intervene there. So I will say that people will begin to use SOFA as a screening tool, but remember, Q-SOFA and SOFA are predictors of mortality. They are not a test of early sepsis at risk to progress to organ failure. So be careful that we are not overutilizing that. I think some sort of a hybrid would be good. Next slide. So that being said, we've talked about the definitions for step 3. So let's go over just briefly step 2 definitions, and I'm actually going to break them down. This slide is overall, gives you everything at a quick glance, and we're going to head to the next slide, and I'm going to kind of break this down for you. So basically our SIRS, which is our systemic inflammatory response syndrome, you guys all know this. It's not necessarily localized. It's a response to an insult. And we know that these inflammatory responses can arise from any kind of chemical, traumatic, or infectious stimuli. And many times it's a reaction to a situation, and it's a consistent group of symptoms that work together. So we know that SIRS can occur for a lot of different reasons. Next slide. The SIRS criteria at my hospital that we've chosen to go with, even though I know CMS says greater than 100.9, so it's actually 101 or greater. We were already, before CMS rolled this out in 2015, we were already working on this project. So we have stuck with what we originally said, greater than 100.4 or less than 96.8. But a lot of institutions have gone with greater than 100.9 or less than 96.8. Heart rate greater than 90, respiratory rate greater than 20 breaths per minute. And we also have in there or CO2 less than 32. And then, of course, your white blood cell count greater than 12,000, less than 4,000, or greater than 10% immature neutrophils, which is your band. Next slide. Now, when we think about sepsis, we want to catch it early. So a lot of the focus with CMS is on severe sepsis and septic shock. So at my institution, we've tried to put a focus as well on sepsis. So if the patient has a known or suspected infection and 2 or more SIRS, it's like game on. We need to go ahead and treat or go ahead and call the provider and see if they want to treat that. We don't necessarily, on the floors, we don't have a nurse-driven protocol on the floors, but in the ICU, in the CVICU, and in the emergency department, this is enough for us to be able to go in and get blood cultures and go ahead and get a lactic acid. Just a moment, I'm going to get a quick drink. Thank you. So that is sepsis. Next slide. Severe sepsis, known or suspected infection plus 2 or more stirs plus organ dysfunction. Now, if you go to the next slide, we'll kind of talk through organ dysfunction. And basically, what I tell my staff is it's a marker. Basically, it's organ dysfunction. It is not something that's ultra difficult. I think when you hear organ dysfunction, you feel like the provider is the one who has to tell you that they have organ dysfunction. But the reality is it's a quick down and dirty assessment. As far as CNS, is there any altered consciousness unrelated to what they came in with? So it's just altered consciousness, or if we're having a change in our Glasgow Coma score. For respiratory, I just say increasing oxygen requirements. If that patient normally lives with oxygen on at home, is it a higher amount of oxygen that we're having to use to sustain them? If so, then that is an organ dysfunction. You can see the total bili greater than or equal to 4, lactate greater than or equal to 2, blood pressure less than 90 millimeters of mercury or 40 millimeters of mercury less than baseline, or a MAP of less than 65. Sometimes my nurses forget and they'll say, well, they're normotensive. I'm like, but they're on a vasopressor. So when you're on a vasopressor, even though it's maintaining their pressure, reminding everyone that is organ dysfunction. And then you can see for renal and you can see for hematologic. So literally having quick down and dirty tick boxes to determine how significant is this for my patient. Next slide. And then septic shock, known or suspected infection plus 2 or more stirs plus organ dysfunction. So basically it's severe sepsis with a lactate greater than or equal to 4 or hypotension. And I should probably have placed on this slide after a fluid bolus. So we know that the patient, if they're initially hypotensive and they are severe sepsis, we give them fluid. If they respond to that, normally they'll stay in that severe sepsis mode. But if they're continued hypotension, they would be in septic shock. So I know that was probably a little bit of overkill. Most of you probably feel very comfortable with that. But I think it's important to know the difference between the sepsis 3 and the sepsis 2 definitions and make sure we're all on the same page. So that brings us to the screening process. It is so important that every hospital have a screening process. I cannot specify that enough. Time is tissue, just like polytrauma, acute MI, or stroke. The speed and appropriateness of therapy administered in those initial moments after severe sepsis occurs, they are definitely likely to influence outcomes. So we want to screen effectively. We want it to become part of the nurse's daily routine. And you really want this part of the admission and shift assessment. Just a moment. Excuse me. I've not talked this much in a couple of days. But the reality is if you don't screen, you're going to miss patients that could have benefited from these interventions. So a screening process is essential. Now, what I'd like to encourage, because the whole topic of this is how we can make our sepsis program improve. And this is one way that I think you can definitely do that. Do you have nursing-driven protocols? Is that appropriate in your state? You have to look at what your criteria is for that. What we did at my institution, we were able to do this. It goes through committee and goes all the way up through our MEC level, where we get approval and then the nurses can practice based on that approval. So we're not just willy-nilly doing this, but it's very specific. That helps us ensure timely interventions, and it also helps us put accountability on nursing, not just providers, but nursing. And then we have a policy that has clearly spelled this out so that all the expectations are very clear. And it's also important that you define a process for what to do with the results of the screen. So you want your nurses to feel very confident on what they do whenever they do have a positive screen. Now, this is just a snapshot, and by the way, I'm happy to send this out to anybody who would like this, but we have a screening protocol for our hospital, and it starts with definitions, but then it very specifically tells who has accountability for what and what the recommendations are that we do. For instance, if you look at the next slide, this is a sample of our emergency department screening tool. Now, this is paper. This is another point that we definitely, you need to always have downtime tools and downtime forms. So I have a lot of screenshots in here that are of actual forms. And I feel very strongly about this because if you ever have a downtime with your computer and you don't have a downtime form, what does that tell the staff? That if it's not important during downtime, why would it be important when we have the regular computer that's up and running, right? So I'm a firm believer that you need to have downtime. So you can see here that the emergency department, when the patient arrives or when they come in and they're being screened, they go ahead and do the SIRS criteria. If they only have one SIRS present, then the nurse has the ability to go ahead and get a CBC, and they can get it with DIF as well. So they can get a CBC with DIF so that they can see their white blood cell count, and they can also see if they have any bands. So that allows the nurse to have some ability to do that. If they have two SIRS present, you can see they automatically can go ahead and get a lactate. They can get blood cultures ×2, and then they have to refer to the provider for the antibiotics and for the fluid. So this is just one sample. And I've seen a lot of conversation about handouts and would like to see forms. I'm definitely a sharer, and I just want you to share back so that we can all learn from each other. So yes, I can give these forms to you guys. Next slide. This next slide is just a paper version of the screening tool for my nurses. Now, I'm going to tell you that it says at the top, within 48 hours post-op CVOR patients. That's like a disclaimer. I personally don't agree with that. I think all of our post-op patients have to be screened, but I will tell you that you do what you have to do to get things through a committee to be the best for the most amount of patients. And my CV surgeons were not in agreement with this initial time. So they are incredibly engaged, though, with the patient's care post-operatively. So I don't want to give you the idea that they don't care about this screen. There is a lot of communication, but as far as us going ahead and getting all the items that we normally would get. But every other patient, you can see here, do they have a known or suspected infection, yes or no? And then you have your SIRS criteria. And then notice we have spelled out very specifically organ dysfunction so that it's really clear with the nurses. This does not mean that the nurses go in and get, like you can see, total serum bili. We're not getting a chem profile every shift. We're not checking their INR every shift. If you have that data, that's where we want you to plug it in, okay? And then it spells out for them. If they have a known or suspected, if they have 2 or more SIRS, we're going to go ahead and get a lactic acid and blood cultures. Now, this particular screening is for my CVICU and ICU. On the floors, then they have a little different screening tool that basically just says they want them to have organ dysfunction before they get those stat labs. So, so there's just a copy of that. So and the other part about this is on the next slide. All of this, most of the time, is done electronically. This is just a screenshot. We use Paragon. If that's helpful for anybody, feel free to use that screenshot to be helpful. But we pretty much have everything electronic. In my emergency department, we have an electronic screen, as well as in the OB department, there's a different electronic screen. When our patients come in for pre-op counseling, there's a question we ask them about, do they have a suspected infection or have they been running a fever? So those kinds of things are done. And most of this is electronic, but reminding you that it is really important not to forget in this computer-driven age, don't forget your downtime forms. I'm a firm believer in those. All right, next slide. Another thing we've done to try to make our sepsis program improve, I am by no means a pediatric or neonatal expert, but there are some guidelines out there to help us, and I will tell you there are some great resources. The only thing my hospital currently does at this time, because we know CMS focuses on adults, we've got, if you look at the next slide, we've got a screening tool. And basically, this screening tool is very specific based on the patient's age, and it allows us to make sure we're not missing anyone. We're currently trialing this in my emergency department, and more to come on this. After 6 months, I believe in May, we'll be looking at our data, and if that's gone well, we'll probably roll this out to my pediatric department, but we've just got a very small pediatric department. If you have a larger pediatric population, or even a small pediatric population, I do recommend that you utilize something for the patients. Next slide. So some other bundle ways to improve compliance, Let's talk through this CMS bundle. Now, we all probably are very aware and very in tune to this CMS bundle, but I wanted to make sure we were all really clear. For the 3-hour bundle, we need to get that initial lactate. We need to get blood cultures prior to antibiotics, and we need to give a broad spectrum antibiotics, and if they meet criteria, that 30 ml per kg of crystalloid fluid. Now remember that 30 ml per kg crystalloid fluid is mainly for the patients who are hypotensive or who have that lactate greater than or equal to 4. That's who it is mandated for. Notice I have an NP. NP means for us at my institution, nursing protocol. So for that initial lactate, those initial blood cultures, and notice over on the 6-hour bundle, that repeat lactate, that is a nursing protocol as well. So for those, anything that's NP, I would go back to accountability to the nurses. Anything else would go with accountability to the providers. And we'll, just to mention, there needs to be some kind of communication with the provider, some kind of grade card or report card to let them know when a patient falls out. Okay, so that's really important. Accountability is very important, and I find that sometimes this is where we fall short. We send out every month all the fallouts, and it goes to all the directors, and basically my abstractor puts in there the department where it fell out. So for instance, if I have a repeat lactate that fell out and I'm the clinical nurse specialist for 3 North, that would be the area as well for follow-up. Now, I do see somebody ask the question, why shouldn't the 3-hour protocol also be used if it is just sepsis before you reach the level of severe sepsis? I think that's from Nancy. Great question. Totally agree. Remember, this is a CMS bundle, and this is what we're held accountable to by CMS. But hands down, I agree with you. If we're at the level of sepsis, let's treat it early and let's get right on it. And that's what my policy says. And I think I had mentioned that a little bit earlier, that many times there is such a focus in institutions on severe sepsis and septic shock because that's what CMS is focusing on. But I agree 100%. So Nancy, keep doing that. You're absolutely right. As far as the severe sepsis bundle goes, repeating that lactate level. And I just want to mention that if you don't have a reflex lactic level from your lab, you definitely need to get this or you will fall out. It's very difficult to remember to go back and get a lactic acid level. So we have it set up through our lab. And most hospitals I work with, they usually have a reflex lactic acid that they incorporate with their lab department. So I highly recommend, if you don't have that, that should definitely help you. I will say, even with our reflex, we still have issues. So for some reason, that doesn't always fire 100% of the time. So just know there's going to be challenges. Now, for the septic shock, patient vasopressors if hypotension persists, and then a volume status and tissue perfusion reassessment if hypotension persists, or if the patient has a lactate greater than or equal to 4. So we're going to go to the next slide and kind of talk about how you can hopefully have improve your sepsis program by the appropriate forms and things for your providers. So as we all know, a focused exam documented by the provider So you can see here vital signs. You can see what that focused exam looks like. Now, what we've done, let's go to the next slide. You can do that, or you can do one of the following: the central venous pressure measurements. You can do central venous oxygen measurements, bedside cardiovascular ultrasound, or passive leg raise or fluid challenge. So I want to just throw this out there. I know that CVP monitoring in the literature has said that CVP is not like the best, but it will help you get, it's a tool in the toolbox, and that's what I tell my staff. We also measure central venous oxygenation. I have my nurses just do that. Once again, that's a protocol. And then my nurses can do passive leg raises. So we have the ability, to do a passive leg raise with non-invasive hemodynamic monitoring or less invasive. So literally looking at stroke volume, we can lift their legs and see if that volume from their lower extremities goes back to their heart. If they have a 10% increase in stroke volume, then the thought is they definitely need volume. So we are all about stroke volume optimization. Next slide. And before we go to the next slide, there's a few questions that have come up, and they're very appropriate to right now what we're speaking about. So are you using nursing protocols for sepsis bundles at your facility? That's really the question. And some of you are saying it's a goal, not yet. Another question came on about, is the repeat lactic acid 6 hours after the first one or 6 hours after initial treatment has been initiated? I'm going to tell you, and this is from Gina, we do this 2 hours after our abnormal one. And the reason we do that, it has to be done within that 6 hour time period. I've had some institutions that do it 3 hours or 4 hours later. The reality is you want it to be meaningful. So usually after your fluid bolus, and hopefully that fluid bolus is in a timely manner. So that's when you're probably going to want to do that. It says, what are the requirements for physician documentation and diagnosis of sepsis? I find that the physician may be treating for sepsis, but fails to mention in diagnosis, therefore it is not coded sepsis. You are going to find that at times these providers don't use the right verbiage. I have been told that even if a nurse screens the patient positive, that counts. The main thing is you want them to treat this appropriately. Yes, we want the provider to document, and hopefully what the form that is on the screen right now, hopefully that will help maybe be something that can help you. This is a sample progress note, and we have developed this for kind of that same reason, Nancy, just so that they can make sure they're very clear. And so it's on their patient known or suspected infection. And then it has their search criteria, has their organ dysfunction, and then it says bundle to be completed within 3 hours. So what that initial lactate level is, that blood cultures are done peripherally ×2. It has their little checkbox for them. Also, I do want to mention, I know I keep saying 30 ml per kg, but you do have a little caveat with CMS, and I've got that listed out here for my providers. So if patient's body BMI is greater than 30, the provider can choose to use ideal body weight. The challenge here is that they have to document what the patient's ideal body weight is and what the patient's BMI is. So I've literally written these things out for the provider so that they can document that and so that they can, it can be very clear, and then a place for provider signature. Now, at my institution, the 3 hour bundle, if the patient comes in through the emergency department, that 3 hour bundle is the requirement of the emergency department. That's just the way it is. It makes most sense, and there needs to be high accountability to the emergency department. And then hopefully that patient will get to another floor. So you can see there's a separate provider signature for the next line that needs to be completed within 6 hours, that repeat lactate. And then if blood pressure is low, that we have given them the appropriate fluid resuscitation, as well as if the blood pressure is low, then we start the Levophed. And then if they have persistent hypotension, as you can see there, the reassessment of volume status and tissue perfusion. Or they can do one of those other items that we discussed. So you can see, let's go to the next slide, and you can see page 2 of that. And this is where we've spelled this out for them. Notice the other little caveat, or the other little good thing, is CMS has said if the doctor, or excuse me, the provider documents that there was a reassessment of volume status and tissue perfusion was completed post-fluid administration. As long as that is documented, then that counts and they don't have to fill out all these other items. I leave all the other items in there, but I did leave a checkbox that says they did do a reassessment. Or I have spelled out one of the following, and then I put the definitions on there as well. Not only did we do this in a paper form, if you go to the next slide, you're going to see this as electronic. So we went ahead and did this, we had providers who wanted electronic progress notes. And so we have gone ahead and put that 3-hour progress note, as well as the, so they've got the 3-hour bundle one, as well as, next slide, I believe shows the, oh, sorry, you were already there. There is 6-hour one. I just, but we put both the 3-hour and 6-hour as an electronic progress note. So I think that is important. Okay, I do see that a question came up. Is it still okay to do 10% less on fluid resuscitation? You know, I've never told my providers that, but whatever CMS has deemed appropriate, and I do believe that's the statement that CMS has said, that is totally appropriate. I've never brought that up to them because I just want them to do 30 ml per kg. But yes, whatever CMS has said, and I do believe that's the correct one. Next slide. So next, let's talk about blood cultures and antibiotics, because that tends to be a challenge. And if you want to improve your program, I firmly believe that there needs to be prompt notification to the provider when the nurse has a positive sepsis screen. And there needs to be a process where cultures are done prior to the antibiotics. One of the challenges that I hear about with the hospitals is sometimes lab is drawing the cultures, and then what happens is sometimes they'll take the blood down, and the nurse knows that they've drawn the blood cultures, so the nurse goes ahead and starts the antibiotics. Well, then they go down to the lab, and then they time it in then. And that can be a challenge. So you really want to work with your lab department. And if lab is not on your sepsis committee, that's the other thing. Everyone really needs to have a sepsis committee and meet to where you can kind of discuss some of these things. So make sure that they are putting the exact time they're drawing the cultures, not when they arrive in the lab. It can make it look like you gave the antibiotic prior to the cultures, and you will fall out on that. Next slide. Lactic acid and repeat lactic acid, I think I might have already mentioned this. See if you can make this part of the protocol for nursing to draw this with the other labs if they screen positive. And then also seeing if your lab can do a reflex order for your elevated lactic acid levels in order to help you maintain compliance. And then make this part of your policy and protocol. Next slide, fluid boluses. So this is another challenge, and the question is how fast should we give fluid, as well as do we put this on gravity or pressure bag? What about our dialysis patient, and what about CHF or a low ejection fraction? So basically we want to give fluid bolus rapidly. Typically IV wide open, pressure bag if necessary. The goal would be around 500 mils every 15 to 30 minutes. Now, that being said, when you think about this, next slide, 1 liter of normal saline adds only 275 milliliters to the patient's plasma volume. So you have to remember that just due to the patient's nature, their leaky capillaries, all of this fluid does not stay in the space where you always want it to. Just a minute, I'm gonna get a quick drink. So just know that that is, that will sometimes help you realize why that patient needs that full 30 ml per kg. Next slide. So I know this goes back a long time ago, 2001, good old Dr. Manny Rivers, in the initial study. I want to just encourage you that, you know, so many of us worry about, are we going to flood our patient? They have heart failure. And I want to remind you about this study by Manny Rivers. If you look at the standard therapy arm and the early goal-directed therapy, back in the day, that's what we called it, and that's the patients who got that back in the day, probably the 20 ml per kg. And you can see this is the percentage of ventilated patients. So let's look at that from 0 to 72 hours after the start of therapy. You can see that early goal-directed therapy group, 55% of patients had to be ventilated, whereas the standard therapy group, 70.6% had to be ventilated. And you can see that the control group, the early goal-directed therapy group had a larger condition of CHF. So sometimes there's this thought out there that these patients are all going to have to be ventilated, and the reality is that's not true. But we want to be mindful for sure of these patients and determine what is the best amount of fluid to give these patients. So I will tell you, I'm all about protocols for volume optimization. I love stroke volume optimization. There are ways you can do this non-invasively now, and then we're not just blindly giving fluid. So if you're really, really worried about your patient, then technology will be your friend. Next slide. So let's talk about, this is just one study that was done by Leesman, and it showed that there was an increase in mortality with later fluid administration. You can see the 13.3% for 30 minutes versus, let's just bump down to the greater than 180 minutes up to 19.7%. There's a lot of studies saying that early fluid does affect the patient positively, but there are also concerns about too much volume in those in that first day as well. So that's where, once again, you've got to determine, are we going to use technology to help us volume optimize? Next slide. Now, when we think about why these patients tend to need fluid, think about your vascular volume. Your vascular volume many times is lost into those interstitial spaces because you have diffuse capillary leaking. So you've got this cytokine release that really damages those vessels. So you have a lot of loss there. And also your patients have GI and skin losses, and also your venous and arteriolar tone is reduced. So your blood volume occupies a larger intravascular space than normal. Only about 40% of normal saline stays in that intravascular space. The rest goes into the interstitial space. And so that is why an initial blood pressure response is not an indication to not give a full bolus. So when you look at this cup with all the holes in it, that was the best way I could find to kind of explain this capillary leak. But that's literally what's happening. We're giving volume in, and then it's leaking out. So volume is important to these patients. And one of the, somebody has asked if that their physicians are are still very conservative with the CHF patients and fluid resuscitation. Do we have any studies that we can provide the physicians? And Joni, yes. So this next slide is for you. This is a study that basically came out of the journal, Society of Critical Care Medicine. It came out in the same journal that the latest guidelines were published in. And basically, it talks very clearly about the application of fluid resuscitation in adult septic shock. So if you have this sepsis-induced hypotension, if your lactate is greater than or equal to 4, or they're hypotensive, then you can see there's 3 arms. The far, as you're facing the screen, the far left arm is no high flow oxygen, no end-stage renal, or they're not on dialysis, they don't have CHF, and we want to rapidly infuse that 30 ml per kg of crystalloid. Notice the middle arm. If the patient has pneumonia or acute lung injury with high flow oxygen requirements, the question is, are they intubated? If they're not intubated, consider intubation to help them facilitate that 30 ml per kg. If we're not going to intubate, it does say a total of 30 ml per kg with frequent reassessments of oxygenation. If they decide to intubate, then you can go ahead and rapidly infuse that 30 ml per kg. And then notice on the far right, it says end-stage renal disease on hemodialysis or has CHF. And it says a total of 30 ml per kg crystalloid with frequent reassessment of oxygenation. And I think this is a very helpful screen. But once again, with those patients who are high risk renal failure and heart failure, you know, this may be somebody you want to stroke volume optimize, and it really can be done very easily now. Technology has come a long way. Next slide. Another thing that we've kind of alluded to already, but based on compliance and how to make our program improve, would be protocol accountability. So if your abstractor is not tracking who is not complying with the bundle, then that needs to happen. And I say your abstractor, the only reason I mention abstractor is because they're the ones in the chart. I don't know, I've got a phenomenal abstractor, so maybe I'm holding the bar too high. She does the report card. She's part of quality, and she also sends out the list of all the fallouts and the data every month, and it goes out to all the nursing directors, as well as she sends the report cards through quality to the providers. What they do is they go ahead and put the number of the provider on the fallout list. We don't know who that is, but my emergency department follows up on a lot of the fallouts, and then they give feedback to the ER doctors, as well as we give feedback to, when I say we, my quality department gives feedback. So accountability is very important, very important. All right, there's some other ideas for improved sepsis care that I just wanted to share with you. And before I do that, we have kind of Pew's criteria for early recognition of infants and children, and how does the neonatal/pediatric protocol you developed, how would that apply? So I am going to be very transparent and tell you that I cannot speak intelligently to the Pew's criteria. I will definitely work on that. I have, my main focus is my adult ICU and my the adult patients, but by all means, I'll be looking into that. So I'm sorry about that. But let's talk about some other ideas that we have done at my institution that maybe can be helpful. We did initiate a code sepsis in 2016. The challenge for us is that we had already been live with our sepsis process for many years, honestly. But we went ahead and implemented this because we thought, you know what, even if a few patients could benefit from this, we want to have that available. So if the patient screens positive for septic shock, they chose to stick with the septic shock. I don't know if I 100% agree with that. A lot of institutions will have a code sepsis for the severe sepsis. I highly recommend that. The way we have it is our nurse communicates with the unit coordinator, our ED communicates with the provider. We have a hotline, which is 5555 at our institution, and we tell the operator code sepsis and what the room number is. What happens then? The team will arrive, and literally it goes to the operator. The operator has a way, we don't overhead this because we don't want 1 million people showing up, but we've got a process where it notifies the appropriate people, and it's the ICU clinical coordinator, which at our institution, that means it's like a ICU charge nurse. Our hospitalist provider, because we have 24/7 hospitalists, and then our clinical pharmacists, if they're available. And basically they go to the site and they help with a 3-hour bundle. They fill out the appropriate paperwork and help to facilitate the patient's movement to the appropriate level of care. Now, what we have is an orange progress note. That progress note that I shared with you already is bright orange. Everything in our hospital related to sepsis is bright orange. I don't know why, I think we thought Tennessee orange, so that's why we kind of went with that. And it's just kind of stuck. We have in that, we have an orange progress note. We also have a bright orange folder that gets pulled, and in that folder, it has everything you would need for that patient. It has the progress note, it has a pathway, it has, it tells you what you need to do. So getting those peripheral blood cultures ×2, grabbing that lactic acid, giving an antibiotic stat, and giving them their fluid if they meet criteria for fluid. Now, next slide. The way this works is just, this kind of spells it out for you, how it's activated. And we have Voceras. I don't know if that's how you guys communicate with people, but after the nurse calls the operator's Vocera, so it's just a device that's on our lapel, and they Vocera the clinical coordinator. They page pharmacy, and they page the hospitalist. And then we go up to the floor and we provide that care. Next slide. We've also updated our rapid response documentation to include positive severe sepsis and septic shock screen. So we basically have on our rapid response, if they don't call a code sepsis, there is a spot in there for onset of severe sepsis or septic shock. So by all means, if they call a rapid response, that's fine as well. We prefer them to call a code sepsis, but either way is fine. And if you look at the next slide then, these are our order sets. And we have a whole order set down there for septic shock treatment. And I'm able, if somebody calls a code sepsis, I can go up to the floor and I can actually I can do the 3-hour bundle within a very short period of time. And once again, that's all part of our protocol. Next slide. So this is a sample of like our sepsis folder. That progress note that I mentioned, it is bright orange in color. We also have in this folder, there's a sheet in there to help you fill out the pathway. That's not a permanent part of the record. Some of my nurses like a clean pathway. The pathway, in fact, I'm not sure if I put a copy of the pathway in there, but it's basically my tool that they fill out in the emergency department as well as on the floors. And it is part of the permanent record. And we also have in that folder a life after sepsis fact sheet. And that's what needs to be given to the patient and family. Next is something else that we've done in order to help us improve our sepsis program is our Ems Sepsis Rollout. So you're going to see that there have been multiple studies done. This particular study was done out of Colorado, and that they had trained paramedics to recognize sepsis in the field. And they found that patients whose caregivers provided those alerts had a median arrival to antibiotic time of 24 minutes less than those whose caregivers did it. So you may think that 24 minutes may seem unimpressive, but if you think about the context of research that demonstrates a 7.6% increase in mortality for every hour delay to antibiotics, it definitely becomes more significant. So I have a phenomenal EMS department, and this is their standing order. And it's pretty wordy, but I think if you go 2 slides down, I kept it all in here so that you could have it in case you want to roll this out. But go 1 more slide down, there's an algorithmic approach. And this is where this is a flow chart. And we literally met with our EMS. We have, like I said, we have multiple counties that report and respond to us, but we have one county that has the majority, and it's our Putnam County. And they are just serious about doing the right thing. And it's been so like refreshing. We were even worried about the amount of work it would take for them. And they're like, we do things a lot harder than this. So what we did was we did some education. It says obvious or suspected infection and 2 or more signs of SIRS or organ dysfunction criteria. So we kind of batched the organ dysfunction criteria and the SIRS to make it easier for somebody on a rig because they're not going to have every single number that we have in the hospital. So you can see MAP, heart rate, respiratory rate, altered mentation from patient's normal, and then they go with temperature greater than 100.4 or less than 96.8. Also, end-tidal CO2, that is their surrogate for lactate, so they are utilizing end-tidal CO2. Notice if they have a known or suspected infection and 2 or more of those criteria, then they declare a code sepsis from the field. And they basically can go ahead and notify the hospital of that. They can, we're going to go back. They can go ahead and do blood cultures ×2, and they can give a fluid bolus in the field, you guys. They can also then give an antibiotic if their blood cultures are done, and then they reassess and they repeat their LR 500 bolus if SIRS criteria remain. The max they can give is 2 liters. If their MAP is less than 65 when they reassess, then they go ahead and start a norepinephrine drip. Now, this is pretty impressive. And the reason this provided us a little bit of nervousness, and if any of you on this call are an infection prevention nurse, my infection prevention nurse was definitely nervous and leery about this. but we decided that we would go ahead and help with the training. So I was not able to be at the training, but we had all the people in place. My emergency department went over, my infection prevention nurse went over, somebody from my lab went over, and we did hardcore teaching on how you draw an appropriate blood culture so that we wouldn't have any contaminated specimens. At my meeting last week, we've had them draw 32 blood cultures. Out of all 32, there's been absolutely no contamination. That's a better contamination rate than my hospital. That is impressive. They also changed their medication out from dopamine to norepinephrine. So that's pretty impressive too. They always carry dopamine on the rig, and they changed that. Then they also, as you can see in the bottom left-hand corner, they have antibiotics, and we included our pharmacy department as well. So they have antibiotics there that they can give in the field. Now, they don't give antibiotics if they don't get 2 blood cultures. So we're really clear about that. We also tell them if there is any reason why they feel like they're not going to be able to get a non-contaminated specimen, just don't worry about it. Still call it in, and we'll get those once they arrive. So this is pretty impressive work. I think we're going to try to publish on it. Very exciting and good stuff. Next slide. So another area that we've worked on to try to improve our program was we have an Upper Cumberland coalition, and probably a lot of your hospitals work with your coalition. And the coalition for us is all our area nursing homes, all of our area home health cares, hospice, things like that in the area and in the region that you support. So this, you can see we had some data that we looked at, and this was in 2017. So we had 147 patients that were discharged with a sepsis diagnosis and readmitted, and this is both inpatient and observation were included. You can see that 40.8% were readmitted from home, but 28.6% were readmitted from home health, and 27.9% were readmitted from skilled nursing facilities. So we realized we had a great opportunity. And so we invited all of our nursing home people that were part of this coalition to a subgroup. And next slide, you're going to see that this is just one of my nursing homes who developed an actual screen, a sepsis screen. How exciting is this that our nursing homes are now going to be screening for sepsis? So they developed a screening tool. They worked with their provider to determine, what can we do? They gave the nurses the verbiage that they needed to say when they called the provider that, hey, the patient has screened positive. And very, very exciting. And so they're literally at the nursing home giving antibiotics, drawing blood, giving IV fluids at the nursing home. If they don't turn around or if they truly are shocked or hypotensive, then those patients will have to come to the hospital. But they've drastically reduced their readmissions to our hospital. Next slide. You can see here, this is the discharge data from this nursing home, and that's total hospital discharges and discharges due to sepsis. So you can see as we were working on this project, they were already decreasing. So that's something that's very exciting. We took them through a multiple program. They met with us multiple times, and we really worked with them on things like CLABSI reduction, CAUTI reduction, just a variety of things, how they're doing mouth care, infection prevention practices, nurse hand washing, and all those things. We really went through a lot of basic things with them. And you're going to see on this next slide that you can see, this is from my colleague's work. She did this as well in Michigan. This was the results combined participating and non-participating SNFs and their readmission rates. And you can see that the participating 30-day readmissions in the red, how it came down, how it's coming down. It looks like they've had some up and down. But the non-participating 30-day readmissions, look how it goes straight up, and the non-participating 90-day readmission. So this is definitely showing some promise, and this is something that can be very helpful. Another thing we've done is every September, Sepsis September is, that's considered kind of your month to really celebrate, not celebrate sepsis, but to really focus on World Sepsis Day. It's always September 13th is World Sepsis Day. This is just one picture. We actually, a lot of those people in the picture, I'm in the middle there with my Got Sepsis shirt, but we have students from the area college who do their clinicals there, and it was a great time for them to give of their time, and they helped us immensely, and we passed out popcorn, and we really wanted to make this kind of a celebration. The next one you can see is from the year before, and then I think I have one more in there, where this time we actually, I'm on the right with our sepsis shirts, and we actually walked around and handed out ice cream to the unit. So another thing, just to remember, you probably are going to want to bring the treats and snacks to them because they're busy taking care of our sepsis patients, right? So very fun and very exciting. Now, I do want to make sure I give you the references for the from the Surviving Sepsis campaign. That is a reference to the guidelines, and it is important that I find that as I go to hospitals, a lot of the coordinators for sepsis, or a lot of the people are very in tune to CMS, but not as in tune to the national guidelines. So I think it's really important that we're all very aware of what these guidelines say, and then you'll really see the correlation and the connection between CMS and the latest guidelines. Another thing I wanted to share with you is that there is a Sepsis Coordinator network, and that is through the Surviving Sepsis campaign. That is not through the Surviving Sepsis campaign. It's actually through Sepsis Alliance. And so I just wanted to mention that to you. This is free, and it's called Sepsis Coordinator Network. You have the information there, how you can log in. This is, like I said, it's totally free, and there are multiple webinars, multiple items, in fact, that you can log into, and like I said, it's free and for everybody in the country, and we're trying to just be a resource and a help for you because we know this is such a difficult and a challenging disease. Now I'd like to just kind of open up the chat box for any more questions. Somebody did ask the question, how often were nursing homes doing the screening on patients discharged back to them? Good question. I believe the nursing home, and if I can, let's see, I believe it was every shift. They actually increased or it might have been every day. I'm having trouble reading that on my small, I would have to check into that for you, but they literally increase the amount of time that they do vital signs now, which is pretty amazing to think that a nursing home would change their whole process for this. So really exciting stuff, and just to know that people are willing to do what they can to try to really help decrease readmission.
Angela, just one more additional question through the chat. And for how long after discharge from the hospital? 1 week or 2 weeks?
That is a great question. I think they were looking at just all readmissions after the hospital. Back to the hospital. So they were just showing a decrease in discharges due to sepsis, and basically showing that, and on the left side, gosh, it doesn't really say what that left, that's the amount of discharges due to sepsis. It looks like they went like October through December, January through March, July, August. So it looks like quarterly they were looking at their discharges due to sepsis. I don't know if that's helpful or not.
And what really impresses me, Angela, is some of the information you shared later in your presentation about the EMS initiative. Working with the community, I think, is such a tremendous opportunity, and we do have some rural hospitals here in the state of Iowa that have implemented programs and coordinated activities with the EMS service. So I think that they'll find that helpful. I'll give everybody just another minute or two to chat in any questions that you might have. But we did pose the question about 20 minutes ago as a challenge to attendees. What are you hearing from this presentation that you think you could act on this week? What could you do today, tomorrow, by the end of the week? What might you look into or follow up on or bring back to your team? And we had a couple of responses back that I'd like to share. And the first one is something that really caught my eye was that we need to remember not only to look at people with temperatures, but also people who have lower temps as well, and looking deeper into our patients. So I thought that that was a really good reflection, Angela. And then another attendee responded, the rapid response documentation for sepsis is something I'd be interested in bringing back to her hospital.
Absolutely. And one thing I just want to mention, somebody.
Go ahead.
I'm sorry. I'm so sorry. I'm talking over you. I apologize. The challenges of technology, right? One of the things I want to mention, you were talking about temperature. You know, I was just at SCCM conference, and what they found was that one of the things that was mentioned was that patients who have a fever have lower mortality, because we're able to recognize it quicker. But those patients who don't have a fever sometimes are not considered as serious. So just something to remember. You made a very good point about the lower temperatures too. You know, that's just equally as concerning as a higher temperature, but yet we tend to focus on those higher temperatures. Good point.
And Sandra had chatted in, she'll be sharing PED sepsis criteria, which I think is a strong takeaway. And Nancy's just added that the downtime form could be very valuable to utilize. She's looking forward to receiving these. And thank you for being willing to share those, Angela. So we'll collect some of those forms from Angela after today's event, and we'll be sending those out to you perhaps in the coming day or two before the end of the week. If you've registered for today's event, we'd be happy to share those on her behalf. It doesn't look like there's any other questions coming in through the chat. So Angela, I'll give you the last word here as we conclude this first session.
Awesome. Well, I just really want to encourage everyone. This is a lot of information. This takes a lot of hard work. And overall in our nation, we're only at about, I think I just heard at the conference, about 40% compliant with the overall, which is dismal, really. And that's with the guidelines that have been set in place. We know that if we have better adherence to the 3-hour bundle, our mortality will decrease. That's just the way it is. I also heard that mortality for septic shock is still around 38 to 42%, and for severe sepsis is around 27 to 32%. That is horrible, right? We would expect that that would be better, but I will tell you that if you implement these 3-hour and 6-hour bundles, you should definitely be able to get that mortality down. And if you have protocols in place, you can definitely make a difference. So take things one step at a time. It's overwhelming. This is a hard initiative, but I'm telling you, if you start with baby steps, you're going to see the results, and that will really empower you. So hang in there. Just know that it's one day at a time, and you can do this.
Thank you so much, Angela, for your robust presentation, and to our attendees for their active engagement in this first session of our learning community. We're just a few minutes ahead of schedule. So with that, I think we will allow everybody to take just a couple-minute break, refill your coffee, take a bathroom break. I want to remind everybody to stay logged into the session through your computer. Although we're on break, you have to remain logged into the session to receive contact hours credit, but we will resume again right on schedule at 10:20 for our next session, which is touching back on Teach Back. Thank you.